Well, thanks for having me, and thank you guys for coming. And I don't know how proud I am of the Ohio State University, who is apparently losing to Minnesota right now. So we'll try not to talk about that. But today, I'll be talking about how I've integrated Checkpoint into my practice, how I use it. And certainly this is pretty informal, so feel free to ask any questions, and we'll have questions at the end as well. And can you all hear me okay? Okay. All right. So a little bit about Checkpoint. It is a biphasic handheld nerve stimulator. And what Checkpoint allows is it allows you to have precise nerve location, so exact identification of the nerve, but also it allows you to identify the location of the nerve. So if you're doing a procedure where you don't really want to completely dissect out the nerve, but you need to know where it is, Checkpoint can help with that. It allows testing of nerve and muscle excitability, and so you can do this at multiple key points and steps during the procedure with really minimal additional time. And it is time-saving. It's handheld. There's no setup. It's very easy to use compared to the alternative of continuous neuromonitoring, which certainly has quite a large setup and time and expense commitment. And how do you use the Checkpoint? The most important thing you want to do when you're starting to use it is to determine what we call the threshold stimulus. And what that is just the minimum stimulus that is needed to produce a visible muscle contraction. And if you put the Checkpoint on a normally functioning nerve that had no tissue between it, so you had the nerve completely exposed, 0.5 milliamps at about 50 to 100 microseconds of pulse is what you need to see a robust muscle response. The Checkpoint, however, can go all the way up to 20 milliamps, and you might need that if the nerve is already strained or bruised, so there's already a pre-existing injury coming in. Or if the nerve isn't visible and you don't routinely expose it, then you need to go up on your milliamps. And there's three settings, 0.5, 2.0, and 20. And then there's a threshold that you can increase within each one of those. And how do you determine the threshold? You place your stimulating tip as close to the nerve as possible. You first ground the needle in the muscle, and then the tip is either on the nerve or as close as possible, and you slowly increase the pulse width until you see the initial muscle contraction. And then you record this number, or memorize the number, or just make a note of it, have your scrub tech make a note, your assistant, and then you can check throughout the case at multiple key points, has this threshold remained the same, or have you had to increase the threshold in order to see the same muscle contraction. And how I started to first use Checkpoint, I started my practice in 2004, and my first experiences with Checkpoint were with the Latarjet. And I had never seen, Latarjet right now is really hot. When I was a resident and a fellow, I had never seen a Latarjet procedure. And I joined OSU in 2006. And at that point, I was the only complex reconstructive surgeon. So we've grown quite a bit over the last 13 years, but I was it when I started. And that was daunting for me. It was overwhelming. There was a ton of hard cases that were just sitting there waiting for me, and I'm fresh out of fellowship. There's a lot of football in Ohio right now, not good football. And there's a lot of bone loss instability cases in Ohio, and I had done all my training on the East Coast, and New York City and DC just is not really football territory. And so there was a lot of these difficult cases waiting for me. And especially when you're teaching yourself a new procedure, this was a scary surgery. There's a lot of nerves very close by in the Latarjet. And I had done a smattering of them, but around 2010 really started to increase the number in my practice just because these patients were coming to Ohio State and it was the right thing for them. And we use, and we still do, interscaling block and interscaling catheters on all of our Latarjets. We do it as an outpatient surgery. And, I have to admit it was a nerve-wracking surgery for me, literally. And I'd leave the OR and I'd talk to the family and I'd have in the back of my mind, I think I did everything right. I don't think I put too much tension on the nerve. But I wouldn't really know when I went and talked to the family if the nerves were okay. And certainly earlier in my career, I would go home and that's all I'd think about that night. Oh my gosh, I hope their nerve works tomorrow. I hope they can supinate the hand. And then you wouldn't really know until we did our post-op call and the catheter wore off. Hey, can you supinate your hand? So it was very stressful for me. And I was at the 2012 ASES biennial meeting, and that's when I first heard about the Checkpoint. And I think Dr. Hausman was giving a talk on it. And I distinctly remember the following week, I had a Latarjet waiting for me and a young, thin girl, so a tiny person, nerves are closed, who had had 3 prior failed stabilization procedures. And I knew it was going to be a scar ball. I knew it was going to be hard. I was stressing about it. And I remember texting my PA and saying, oh my gosh, I just heard about this awesome device. Find the people, find it. I want to use that for my case. And it was really, it helped me identify and know where the nerves were in a very scarred surgery. It gave me confidence to go talk to the family that everything's okay. Because, you know, we're in the age now where everyone Googles. I have patients come in and say, so tell me about your nerve complication rate. People know what the risks are of surgery. They know what we worry about. And so ever since then, I've used the Checkpoint on all of my Latarjets. And it's interesting because around this time in 2012 is when all the papers started to come out with citing the nerve injuries. And in 2012, the Harvard paper came out showing a 10% neurologic injury, mostly muscocutaneous, axillary, and radial nerve. And then Greaser, who's actually one of our residents, we did this with Tony Miniacci at Cleveland, did a systematic review and found a 2% neurovascular complication rate. And then Gartzman in 2017 looked at about 416 Latarjets and found a 3% neurologic injury. So, you know, a wide variety, but I think the most daunting paper is the one that won the Neer Award in 2014, which really, I think, started getting everyone talking about the nerve injuries because they did continuous neuromonitoring on 34 patients. And they found that 76, 77% of these patients had a nerve alert during the surgery. About half, a little over half axillary, 22 were muscocutaneous. And then they found 21% had a clinically detectable nerve deficit after surgery. Now, the one thing about this paper is that these patients didn't have a block, they didn't have a catheter, they examined them in the recovery room. And a lot of these deficits, I mean, 21% deficit is pretty high. A lot of them were sensory and they were detected in the recovery room. But still, if you have a sensory deficit, that's one step away from a motor deficit. And what they found is that the greatest risk of a nerve alert was during glenoid exposure and then graft insertion. And certainly glenoid exposure can be very challenging. Really, you're exposing the anterior scapula. And the traction on the axillary nerve can be significant. And then graft insertion, you're at risk for, if you put the graft too low, impinging on the axillary nerve, but also moving the conjoint tendon over. If you haven't freed up the fascia between the conjoint tendon and the pec minor very well, that's where a tether can occur in addition. And so that's when they detected, and that makes sense, when the nerve alerts. So what we decided to do, because that paper came out in 2014, is I said, well, I've been using the Checkpoint now for 2 years. At that point, we had 37 patients that we had used it on. Let's look at what we found in our paper, or in our population. So we had average age 23, majority were males, over half were revisions, so what you'd normally expect for Latarjet. Smaller patients, you know, BMI of 26, more physically fit people. Unfortunately, about 30% smokers, and you do wonder about smoking and its risk factors for nerve injuries. And at that time, average length of surgery start to finish was about 2 hours. And what we found is that with checking at multiple time points during the surgery with the Checkpoint, we didn't find any detectable change in our stimulus threshold. We didn't have to reposition any of our grafts. And we didn't have any intraoperative evidence of excessive traction on either the axillary or the muscocutaneous nerve, which I know the one paper showed an injury to the radial nerve, but I think these are two really the nerves that are they're right in your surgical field. Now, all of our patients did have a block and a catheter, so we did not get to do a first exam until 10 days. So certainly we may have missed transient sensory deficits that the other paper with continuous nerve monitoring detected. But really what we were worried about was catastrophic injury, clinically detectable, clinically relevant injuries. And then we had no deficits this was just short-term 3-month follow-up. And if you didn't have anything at 10 days, you know, you wouldn't expect something at 3 months. And when you think about continuous nerve monitoring, you are more aware of nerve events during the entire procedure. But I think the question is, how well does this translate to relevant clinical issues? And I think that continuous nerve monitoring certainly can detect if a clinically relevant deficit is imminent. So if you are hauling on the axillary nerve to get your graft in, certainly continuous monitoring will start to let you know, hey, you need to let off. So I think that certainly it can allow repositioning, reevaluation to avoid a catastrophic injury. However, it's timely, it's costly, it's not widely available, and it's really not practical for most people, even in an academic center. I'd get shot at Ohio State if every time I did a Latarjet, I did neuromonitoring. I mean, we do our Latarjets in our surgery center. There's not the ability to do that there. I can't get neurologists to come over, and our surgery center functions like a efficient surgery center. But certainly continuous monitoring is the gold standard, but I would bet not many people are doing this at this point. But we know that the injury risk is there, and so I think having something that meets in the middle is really helpful. And the checkpoint allows us to avoid a catastrophic deficit. Now, if I cut the nerve, the checkpoint is not going to let me do that. It's not going to let me stop that, or it'll tell me afterwards. But really, that's not what most people do during a Latarjet. It's the traction, it's the tension on the nerve, which is really what the risk is. And so you can check it at multiple times during the procedure and readjust if you need to. And then it doesn't alarm us about things that are maybe clinically non-detectable. So it would be very stressful. Think about the time it takes to do a Latarjet if you have that many nerve alerts and you have to stop and reposition and pause every time, and the time that adds. I think you leave the OR with confidence that you didn't have a catastrophic injury. And I think it's really helpful in the world we live in, and everyone knows about the nerve risk. It gives you backup and support in litigation cases, and you can document that you used a form of neuroprotection during a complex surgery. I think it's easily utilized by the community surgeon. It's easy to have on your shelf. It's easy to have available. And I think it gives you, for me, I needed peace of mind, and it really helped with that, and it helped me get a good night's rest after this procedure. But what I think mostly the Checkpoint has done for me is it's made me a better surgeon. Because when I was training, we had a surgeon in my residency that said, for shoulders, for total shoulders, that would told me, Julie, you don't go looking for the nerve and it won't come looking for you. And I don't think that's really the best logic. The Checkpoint has made me, I find it, and it's made me know where the nerve is, and then I think my risk of a nerve injury has gone down as time has gone on because I've forced myself to find it. I know where it is. I know where the muscocutaneous nerve is. I've seen a lot of variability where it is from patient to patient, so it helps me understand the variability of where the nerve is. And so I think it has made me know where important structures are and be more confident, not afraid, but confident that I know where the nerve is. And I think for medical malpractice, what they say about malpractice is that it can only be shown when the physician has a duty to the patient, that duty to the patient has been breached, the patient has been injured, and the belief is that the breach has reasonably led to the injury to the patient. And this paper was a nerve injury paper in 2008, which I think says it very nicely, that the surgeon who attempts to identify and preserve the nerve is likely less vulnerable to allegations of breach of duty. Regardless of whether surgeons consider careful surgical technique and preservation of the nerve to be standard of care, the legal system clearly treats it as such. And it's very reassuring to the parents, because a lot of the Latarjets that I do are on 17-year-olds. And the parents, they say, what are the risks? Well, these are the risks, but you know what? I use a special nerve monitor during surgery. We're aware of where the nerves are, and I said that helps me do a better job. And I think that is very helpful for everybody. And how do we use a checkpoint during the Latarjet, or how I do it? I identify the nerve at the beginning of the case, so I do muscocutaneous first. And typically you can find the muscocutaneous at the inferior border of the pec minor. I do not dissect it out. I do not look right at it. I can palpate it, I can find it, and then I check and note the threshold stimulus. And it's higher. I'm never at 0.5 milliamps because there's always a little soft tissue between me and the nerve. And then I check it after I've done all the work on the coracoid, because I do release the fascia between conjoint and pec minor. And so I release everything, I free everything up, and I check it again to make sure, okay, I haven't done anything. And then after the transfer is complete, I check a final time just to make sure. Now, the one thing to keep in mind if you use Checkpoint is you need to have a dialogue with anesthesia about paralysis. Because if they have paralyzed the patient and you don't know it, and then the Checkpoint is not working, There is one patient that I think I had a nervous breakdown during the surgery, because we don't paralyze these patients, and I wasn't expecting the patient to be paralyzed, and I could not get the muscocutaneous to fire. And finally I thought, hey, did you guys paralyze the patient? And then I realized the patient was paralyzed, didn't have any twitches back, and that's why it wasn't firing. So it's something you want to discuss with anesthesia and make sure you know what they've given. Different aids for paralysis can have different effects on, even if the twitches are back, they might tell you all 4 twitches are back, but the muscle or the nerve still might not be as receptive. And here's just not, it's hard to see because I don't dissect out, but you can see the perineural fat. I release the pec minor, and then right at the inferior, the pec minor always retracts media a little bit, and I find the nerve, and then here is just, you know, the amount of little bit of biceps firing. So it's a minimum amount to get that biceps to fire. Oh, there it is again. And then for the axillary, prior to glenoid exposure, I identify the nerve, and it's much easier to identify the axillary nerve. So typically, I'm on a much lower, either 0.5 or 2 milliamps, because you can typically feel it and see it. But there's always a little soft tissue around it, a little that might take you up to 2. So I record the threshold, I expose the glenoid, and then I check again. And then I check also after the transfer is complete, because certainly if you do put the transfer a little too low, the coracoid can be impinging on the nerve. So those are the 3 times that I check. And a lot of times you can check muscocutaneous and axillary together, so it's not like you're coming in and out too many times. And then here is just, we ground it in the deltoid and are putting the tip on the nerve. And then this is typically the amount of, you know, it's probably a little vigorous. I probably can go down so you see my finger just went down a little bit. And then you have your finger on the button to increase the width of the pulse to get that minimum amount. And it just really gives you a good sense of satisfaction and confidence. So aside from the Latarjet, when else do I use Checkpoint? For reverse total shoulder, there's about a up to 4% injury rate to the axillary nerve. It's believed to be due to humeral lengthening. And you know, we published a paper a couple years ago about my reverse patient population who was at risk for a nerve injury. And I had 4 patients that had a brachial plexopathy after a reverse. And the only common denominator that we found in these patients, smoking, revisions, everything, we looked at lengthening, was their BMI. And so in ladies, small ladies with under 20 BMI, those are the 4 nerve injuries that I had. And you know, we worry about, did subtle lengthening, even though it wasn't radiographically significant, put a strain on the nerve? And so especially with some of these patients that are really tight, that are small, that don't have a lot of room, you can use the Checkpoint here to see, with different size trial components, can you get that same threshold stimulus or not? And you can downsize the component, but obviously you've got to balance it between instability and the proper lengthening. But it's something that's on the shelf. If I need it, I can have them get it. For revision total shoulders, these can be really difficult, and it's hard to identify the axillary nerve, and sometimes you don't really want to completely dissect out the axillary nerve, but you want to know where it is. And so the Checkpoint has been really helpful for me to find, okay, where is the nerve, and then what can I release? So if I kind of find the location of the nerve, and then I know, okay, everything above it is safe for me to release. Or if you do identify the nerve and it's been really scarred in and you need a neurolysis, I think that the Checkpoint can help that, because if you do completely identify the nerve and it takes you a 20 milliamp to get it to fire, then you might want someone like Dr. Hausman to come do a neurolysis for you. And then in periprosthetic fractures, I try to keep these to a minimum, but they do occur. And what I found is it's really helpful to find the radial nerve distally if your fracture extends that far, because you know, if you're doing a periprosthetic fracture, you normally are using a delta pec approach, which is extensile. You're not going to add, it's just not practical to put a posterior incision to find the axillary nerve posteriorly. And so the Checkpoint's been really helpful. We did this case just a couple months ago. This is a dislocated total shoulder. Hard to appreciate the fracture lines well, but the patient had a pretty long oblique fracture that was unstable. And we revised it to this reverse. And that distal cable the nerve is right next to that cable. And certainly it's been reported, and it is possible to put a cable on a nerve if you can't visualize the nerve. And so the checkpoint was a salvation during this case because we were confident, okay, there's the nerve, we haven't damaged it, we're gonna, put a loop around it and we can calmly put our cables on without being fearful. And the checkpoint led us to the nerve and helped us find it. So I think during these cases it was helpful. And then obviously it was a dislocated total shoulder, a lot of scar tissue proximally, pretty big exposure for the base plate. It helped us find the axillary nerve. So for myself, these have been the times where I use it the most. I don't do any elbow surgery, but I think Dr. Hausman does a ton. So he will come up and tell us about his experience.